بسم الله الرحمن الرحيم. We will start the session, Cancer Care. It's an honor to present Professor Helmi Mtawa, the head of Gynecology at Ain Shams University. He will talk about fertility-sparing surgery in gynecological cancer.
Thank you, Mr. Chairman. أحب أشكر اللجنة المنظمة للمؤتمر ودعوتي لإلقاء توك. طبعا إن شاء الله أعرف كلكم تعبانين فإحنا مش هنطول، يعني 10 دقايق كده كل سيشن إن شاء الله. سريعا هنتكلم على الفيرتيلتي سبيرنج سيرجري in gynecological cancer. The main purpose of cancer therapy is high cure, low morbidity, high level of quality of life as a mood, sexual life, cosmetic appearance, and fertility preservation. All therapeutic modalities in female cancer are associated with infertility due to the effect of radiation or radical surgery and effect of chemotherapy. Fertility sparing surgery instead of radical in early stage selected gynecological cancer is performed by different centers. ابتدى different centers كتير. طبعا أهم حاجة في الفيرتيليتي preservation البيشنت selection. Fertility sparing surgery objectives similar oncologic outcome to standard therapy, favorable obstetric outcome, the benefits more than the risks, low morbidity and cost. Benefit of fertility sparing surgery, preservation of fertility and maintenance of endocrine function to avoid the menopausal symptoms. The risk increase probability of recurrence and death, additional surgery. The main requirements of fertility sparing surgery, preservation of the uterus and at least one functioning ovary. Fertility sparing surgery بتعتمد طبعا على type of the tumor, origin of the tumor, stage, grade, histology, age, performance, the availability of fertility assisted reproduction, fertility desire, previous infertility problems, and close follow-up. Indications of fertility saving surgery عندنا بالنسبة للأوفيريان كانسر وعندنا endometrial كانسر وعندنا cervical كانسر. دول ال 3 types of gynecological cancer اللي نقدر نعمل فيهم fertility preservation. بس طبعا عشان أعمل fertility preservation لازم يتوفر عندي إن الستيج بتاع التيومر بيبقى early stage والجريد بتاع التيومر بيبقى low grade. يعني دايما فيرست طبعا الحفاظ على الحياة. الحاجة الثانية الفيرتيليتي. انديكيشن فيرتيليتي اول جيرم سيل تيومر. الجيرم سيل تيومر من الحاجات اللي هو تشخيصها سهل، انها بتيجي دايما في الفيرست والسكند ديكيدز اوف لايف، والعيانه البرزنتيشن بتاعها عاده بيبقى ابدومينال بين، وتيجي تعمل الترا ساوند او تعمل MRI تلاقي فيها اوفيريان ماس. وسهل تشخيصها لما تطلب التيومر ماركرز زي البيتا اتش سي جي والالفا فيتو بروتين LDH، بتلاقي التيومر ماركرز بتبقى هايلي اليفيتد، فيبقى تشخيصها فيري ستريت فورورد. وده ستريكتلي طبعا لما تيجي سعادتك تعمل السيرجري فيهم بنعمل ابسي لاترال ليمفادينكتمي اومنتكتمي اند يونيلاترال ادريكسكتمي، نعمل بريزرفيشن اليوترس والاذر اوفري، وبعد كده العيانه تاخد ادجوفنت كيموثيرابي اكوردنج لنوع الجيرم سيل تيومر. انديكيتد برضه في السكس كورد سترومال تيومر، البوردر لاين اوفيريان تيومر. Regarding invasive ovarian cancer only stage 1 grade 1 tumor دول كان انك تعمل لهم fertility preservation. الكانسر سيرفكس الايرلي ستيج اللي هي ستيج 1 A1 وستيج 1 A2 وال1 B2 اقل من 2 سم، دول عيين كانديد ان انت ممكن تعمل فيهم fertility preservation. اندوميتريال كارسينوما لازم تبقى طبعا فيرست ستيج تيومر، بتبقى low grade وتبقى well differentiated tumor. Fertility sparing surgery, adequate surgical staging, removal of the affected ovary and tube, preservation of the uterus and the contralateral ovary, final evaluation of normal appearing contralateral ovary and endometrium. دي عيانة كان عندها جرانيولوزا سيل تيومر، عندها 27 سنة وعندها ادريكسيال ماس. البري اوبريتيف ورك اب بتاعها كان عندها الاي ام اتش كان عالي والسيرم انهبين كان عالي، فعملنا لها ادريكسكتومي وعملنا كونزرفيشن للاذر اوفري. ده الاوفنتكتومي، ده الليمفادينكتومي، ده الاوفيريان ماس. ده المنظر بعد ما عملنا الكونزرفيشن. fertility sparing surgery epithelial ovarian cancer. About 25 to 30% of all epithelial ovarian cancer are early stage at diagnosis. 14% of epithelial ovarian cancer occur under the age of 40. Those of these 62% will be stage 1 and stage 2A. Not all, many of these desire to preserve fertility. يعني epithelial ovarian cancer الحاجة اللي هعمل فيها conservation stage 1A وجريد 1. ما عدا ذلك هعمل الفورمال سيرجري فور كانسر اوفري. 6 كورد ستروما تيومر او الجيرم سيل تيومر ده انديكيشن ان انت تعمل فيها fertility preservation، ان عاده دي بتيجي في اليونج ايج. indication of fertility sparing surgery epithelial ovarian cancer stage 1 grade 1، احيانا في stage 1 grade 2 limited cases، stage 1C grade 3 clear cell زائد chemotherapy دي very limited cases. المين بروبلم ان fertility sparing surgery epithelial ovarian cancer الاوكالت ميتاسيس وريلابس ان سبيرد اوفري. اوكالت ميتاسيس في النورمال appearing اوفري تقريبا حوالي 2.5%. Survival after fertility sparing surgery in patients with early ovarian cancer without chemotherapy is about 94%. Fertility sparing surgery in borderline, you can spare the ovary and the uterus in all cases of borderline tumor, especially ovarian borderline tumor usually present in early stage and before the age of 40. Ovarian procedures in bilateral ovarian borderline ovarian tumor include unilateral salpingo-oophorectomy, ovarian cystectomy, partial excision, or cortical ovarian biopsy for cryopreservation. Recurrence after fertility sparing is about 7.7 to 31%. Disease-related death 0%. Pregnancy rate is about 31.8. fertility sparing in germ cell tumor زي ما قلنا الجيرم سيل تيومر عادة بتيجي في الفيرست والسكند ديكيد اوف لايف، وعادة بتبقى يونيلاترال تيومر اكسبت الديشيرونوما بتبقى بايلاترال في حوالي 10 15%. فعادة العيين دول طبعا بنعمل لهم كونزرفيشن، نعمل يونيلاترال ادنكسكتومي ستيجنج وكونزرف على اليوترس اند اذر اوفري. After fertility sparing surgery, epithelial ovarian cancer, malignant ovarian germ cell tumor والborderline ovarian tumor survival is similar to radical surgery عشان احنا طبعا السلكشن بتاع الكيسز. Regarding endometrial carcinoma طبعا دي الموست كومن gynecological cancer، وعادة الاندوميتريال كارسوما بتبقى بريزنتد في البوست منبوز، ولكن تقريبا حوالي 20% من البرزنتيشن بتاع الاندوميتريال كارسوما بيبقى في البريمينيبوز، وحوالي 4% تقريبا بيحصل قبل سن 40 سنه، خصوصا لو عيانه اوبيز او عيانه عندها بوليسيستيك اوفيريان ديزيز. عشان نعمل كونزرفيشن في العيانه الاندوميتريال كارسوما لازم تبقى ستيج 1A وتبقى ويل ديفرنشيتد تيومر. وقبل ما اعمل طبعا اخد القرار بتاع الكونزرفيشن في العيانه اللي هي الاندوميترويد ادنوكارسوما لازم اعمل لها MRI وميتاستاتيك ورك اب اتاكد ان التيوبر كونفاين تو ذا اندوميتريوم، مفيش عندي ليمف نود، ما عنديش ميتاسيس لومنتم او لانج ميتاسيس. ده الستاندرد ثيرابي بتاع الاندوميتريال كارسينوما، بعمل بان هيستريكتومي وميتكتومي اند بايلاترال ليمفادينكتومي. بري تريتمنت ايفالويشن زي ما قلنا ان احنا بنعمل ترانس فاجينال الترا ساوند، بنعمل MRI عشان نتاكد تماما ان مفيش عندي اي ميتاستاتيك ورك اب، مفيش اي تيومر اوتسايد اليوترس. ده الMRI قبل وبعد التريتمنت. المين تريتمنت بتاع الاندوميتريال كارسينوما بناخد هاي دوز بروجستين، والبيست اوت كاب مع ان احنا بنعمل ريسكشن للهيستروسكوبيك ريسكشن اوف فوكال اندوميتريال كارسينوما، ونعمل ريسكشن للادجيسنت اندوميتريوم، واعمل ريسكشن للاندرلاينج 3 to 4 ملم من مايوميتريوم، followed by application of marina loop and systemic بيجاس بندي تقريبا حوالي 160 مللي جرام بير داي، واسس الريسبونس بعد 3 شهور اعمل هيستروسكوبي وانذر بايوبسي. لو العيانه حصل فيها كومبليت ريسبونس خلاص بحولها لدكتور الفيرتيليتي عشان تبدا القصه بتاع الفيرتيليتي. لو كان في بارشال ريسبونس ابتدي ارفع الجرعه، بدل ما ادي 160 مللي جرام ممكن اديها 320 مللي جرام واسس الريسبونس بعد 3 شهور تاني. لو ستيل في جود ريسبونس خلاص، لو ستيل نو ريسبونس ببقى بروسيد فور سيرجيكال ستيجنج وهيستريكتومي. الانديكيشن طبعا العيانه لازم تبقى يونج ايج اقل من 40 سنه، التيومر تبقى ويل ديفرنشيتد، تبقى ستيج 1 جريد 1 ومفيش كونترا انديكيشن للبروجستين ثيرابي، وبعمل ايفالويشن كل 3 شهور الريسبونس بتاع العيانه. ريجاردنج الكانسر سيرفكس طبعا الكلاسيك سبيكينج ان احنا بنعمل فيرتايم اوبريشن او راديكال ابدومينال هيستريكتومي وبايلاترال سالبينجو اوفريكتومي. الفيرتيليتي سبيرنج في السيرفايكال كانسر لازم الحاجات الميكروسكوبيك ستيج 1 A1 والليمفو فاسكولار سبيس انفيجن نيجاتيف وي كان جو فور كون بايوبسي. ستيج 1 A وفيها ليمفو فاسكولار سبيس بوزيتيف او ستيج A 2 او 1 B 1 دي بتعمل راديكال تراكليكتومي اند بايلاترال بيلفيك ليمفادينكتومي بكونزيرف اليوترس، وبعد كده بعمل انستموزس للكوربس مع الفاجانا واحط بيرمننت سيركلاج في العيانه. الكون طبعا ده الكون بايوبسي من السيرفكس، فالانديكيشن بتاعه لا ايرلي ستيج اوف كانسر سيرفكس. ال1 A2 نعمل لها ليمفادينكتومي وراديكال تراكليكتومي اند سيرفايكال سيركلاج. 1B1 اللي بتبقى تيومر اقل من 2 سم we can go for radical trachelectomy. radical trachelectomy removal of the primary tumor، بشيل البارامتريوم، بشيل الابر 2 to 3 سم من الفاجينا، وبشيل الليمف نود. ممكن تعملها ابدومينال اور فاجينال. ده صوره الراديكال تراكليكتومي. reproductive outcome after trachelectomy 25 to 43% of infertility. الاوبستريك اوتكم طبعا مشاكل الراديكال تراكليكتومي الميد ترابستريك لوس او البري تيرم ليبر في نسبه حوالي 25%. conclusion conservation conservative surgery embryo cryopreservation oocyte cryopreservation ovarian tissue cryopreservation. لو انا ما قدرتش اعمل fertility sparing surgery ممكن اقدر ارجع اعمل oocyte او ovarian tissue cryopreservation او embryo cryopreservation او ovarian suppression. شكرا جزيلا.
شكرا جزيلا دكتور حلمي على المحاضرة القيمة. أنا عندي سؤال. حضرتك قلت one of the indications of fertility sparing for epithelial ovarian cancer stage 1C clear cell. مش عارف أنا clear cell دايما ببقى it's a nightmare for me. إيه رأيك؟
الكلير سيل كارسينوما طبعا او السيرس كارسينوما اللي هم التايب 2 طبعا البروجنوز بتاعهم بيبقى بور بروجنوز، فاللي اتوصف في الابيثيليال اللي هو ستيج 1 ايه بتبقى ويل ديفرنشيتد. ناس اشتغلت على حاجات اللي هي السيرس او الكلير بس طبعا دي عدد حالات قليل، انما الستاندرد في الابيثيليال اللي هي بتبقى ويل ديفرنشيتد وايرلي ستيج.
شكرا جزيلا. Next speaker, updates in FIGO staging of endometrial cancer, Professor Dina Saman.
Okay, so good evening, everyone. Only survivors reached the gynecology session, so This is Dina Samin. I will be talking today about a current hot topic, which is the FIGO staging 2023 of the endometrial cancer. But firstly, let me express my deepest gratitude to Professor Hilmi Mtawa for sending me this kind invitation, as well as the conference board. Okay, so to begin with, this publication actually is the essence of today's talk, where Jonathan Barak et al. They gathered and met frequently, and they saw all the updates in the treatment, the staging, and prognosis. They also used all the updates published by the ESGO, the ESTRO, and the ESP as regards the classification of endometrial carcinoma, including the histopathology and the molecular stuff, and they used them as a template for the new classification. Actually, the ESGO had a nice prognostic risk stratification group where they classified the patients into low, intermediate, high, and advanced according to whether the molecular status is known or not known. Okay, and it's not working. Okay. This sheds the light on importance of the involvement of the molecular typing and some of the histopathologic parameter in the staging thing. Okay, and then the FIGO committee came up with new staging through a publication in the June 2023, like after 15 years on the very well-known FIGO 2009 that you all know. Now, what's the major difference between the stages 1 and 2 versus 3 and 4 in the new classification? Actually, all are surgically anatomically designated, whereas only stage 1 and stage 2 are affected by the histopathological and molecular imprints. Okay. My talk today will be in two parts. First part will be comparing between the old classification versus the new one. The second part, I'll be answering some questions maybe in your head. So what about the new classification? The stages, the major stages. In stage 1, they're talking about the uterine corpse together with ovarian involvement, and that's actually new. The stage 2, they're talking about cervical stromal invasion. This is aligns with the old one, but in addition to lymphovascular invasion, okay, that is substantial, or the existence of an aggressive subtype with my invasion. Stage 3, they're talking about local and regional spread, and stage 4 are talking about mucosal spread to the bladder and the colon together with distant spread. Okay. It's not working very well, by the way. Okay, so let's see what's the difference between the old stage 1 and the new stage 1. The old stage 1 was the one concerned with the tumor that is confined to the uterine corpse, with the stage 1A, the substage 1A versus 1B, with respect to the myometrial involvement, 50% as a cutoff value below and above. The new stage 1, it's substaged into 1A, 1B, and 1C, taking into consideration actually the histopathologic subtypes, where the A and the B are non-aggressive subtypes, and the C are talking about aggressive subtype. They're taking into consideration again, there's the extension and the LVI, where the 1A1 and the 1C are limited to the endometrial polyp or confined to the endometrium. The 1A2 with myometrial invasion that is less than 50% with or without focal LVI, and the 1B is more than 50% again with or without focal LVI. The 1A3 is another new substage that is limited to the uterus and the ovary. Now, what about the difference between the stage 2, the old one, and the new one? Okay. The old stage 1, they've been talking about cervical stromal invasion and full stop. As for the new stage 2, we have 3 substages, the 2A, the 2B, and the 2C. The 2A is the one that aligns actually with the old stage 2, including cervical stromal invasion with a non-aggressive subtype. The 2B is again involving non-aggressive subtype but with substantial LVI, and I'll be telling you what is substantial LVI in the part 2 of the lecture. And the 2C is involvement of any myometrial invasion with an aggressive subtype. Now, this is a demo showing the stage 2 and its substages. Okay, before I go to the stage 3, let me emphasize the fact that the molecular subtyping would definitely affect the staging for stage 1 and stage 2, and I'll be talking about this again in part 2 of my talk. Okay, let's go to stage 3. The stage 3 that you all know has the A, B, and C for the C1 and the C2. And now the new stage 3, they're talking actually about, again, A, B, and C, but stages 3A and 3B has substages 3A1 and 3A2, and 3B1 and 3B2. What about the 3A1? It includes the ovarian or fallopian tube. Somebody would ask me, haven't you just mentioned ovarian and uterine involvement in stage 1A3? Yes, actually, this is true, and there's a major difference between both. I'll be explaining in a while. The 3A2 involving the subserosa or the serosa. The 3B, the 3B1 aligns with the old 3B actually, including the vaginal parametrial, whether direct or metastatic. The 3B2 is another new entity that is including the metastatic or direct invasion to the pelvic peritoneum. Now let me tell you something. The old classification, the pelvic peritoneum involvement used to be considered as stage 4, and this meant that those patients would not receive any surgical intervention. As for the new staging, pelvic peritoneum, and I'm stressing only pelvic peritoneum involvement, is considered as stage 3B2 and giving hope for patients with some surgical options. Okay, now what's the difference or the landmark between the pelvic carcinomatosis and the extrapelvic? I mean the pelvic peritoneal involvement and the abdominal peritoneal involvement. It's actually a line joining the two anterior superior iliac spines. Okay, back again to stage 3. The 3C still has the 3C1 for the pelvic lymph nodes, the 3C2 for the paraortic with or without the pelvic, but we have the substages with the I, which is for micrometastasis, and the double I for macrometastasis. Again, what makes me design a paraortic lymph node as stage 3 versus other paraortic lymph nodes as stage 4? Actually, it's the upper limit of the renal vessels. Below the renal vessels, we're stage 3, and involvement of paraortic above renal vessels, we are stage 4. Okay, and that's a demo. Go to the stage 4. Stage 4, the old one that you all know, has been 4A and for the bladder intestinal mucosa, and 4B for the distant mets. Now the new stage 4 actually is substage into A, B, and C. Again, A aligns with the old A, including the bladder or the intestinal or the bowel mucosa. The 4B includes the abdominal peritoneal, and now we know the difference between pelvic peritoneal involvement versus abdominal peritoneal involvement pathologically and actually clinically. And the 4C includes distant mets, including lymph nodes intra or extra abdominal, lung, liver, brain, or bone. Okay, and that's again a demo showing the stage 4 and its stages. To sum up, actually the ones highlighted in the yellow are the new substages that are added to the FIGO 2023 versus the FIGO 2009. Now did I come to the end of my lecture? No, actually, because I believe that you still have questions in your head. Now we have 6 quick questions to answer. The question number 1, what about the histologic types? Dina, I've been talking about aggressive versus non-aggressive. So what's the difference? Actually, according to the WHO, the latest edition, they said that the non-aggressive subtypes include the endometrioid endometrial carcinoma grade 1 and 2 only, whereas the rest, whether the endometrial grade 3, the serous, the clear, undifferentiated, the mixed, the GI mucinous, the mesonephric and the mesonephric-like, the carcinosarcoma, all of these are considered as aggressive subtype. Okay, now what about the grading? Again, only the endometrial carcinoma is the one that is graded actually into 3 grades, whereas the rest are high grade by definition. So how do we grade the endometrioid endometrial carcinoma? Actually, by the existence of the solid gross component, we can classify them into low grade and high grade binary system. This is the one that oncologists rely on, or into 3 tier system, including grade 1, 2, and 3. And this is actually of benefit for the fertility preservation group, where they can do some measures for cases of grade 1. Now, what about the lymphovascular space invasion? By lymphovascular space invasion, I mean the blood vessel or lymphatic vessel have tumor cells inside. Actually, if you have 4 or less vessels involved, we call this focal lymphovascular space invasion. If you have 5 or more, we call this substantial or extensive, and I believe you have seen how this actually affected the staging. Now, what about the adnexal involvement? You told us that uterus plus ovary can come in stage 1, uterus and ovary can come in stage 3. Now, what's the difference? On the clinical level, there's a paramount difference. With the stage 1, definitely they have better prognosis. They do not need adjuvant therapy, whereas stage 3 have worse prognosis and need adjuvant therapy. But how can I differentiate between both? Firstly, let me tell you that we're talking about low-grade endometrioid endometrial carcinoma, okay? But I have 4 more conditions to say it's stage 1, including less than 50% myometrial invasion, no substantial or extensive LVI, no other mets, even the ovarian involvement should be unilateral without any capsular invasion or breach, then I can designate it as stage 1A3. Otherwise, this is stage 3A1 and considered as mets. Okay. Now, what about the lymph nodes? Lymph nodes are either positive or negative. The positive ones are reported according to the number and the size of cells as isolated tumor cells, and this does not affect the staging actually, into micro or macro metastasis. But it's noteworthy that the guidelines of the ESGO, the ASTRO, the ESP, and even the FIGO, they allow an approach of sentinel lymph node biopsy in all patients with endometrial carcinoma, because sentinel lymph node biopsies help rule out occult lymph node mets and staging as well. They also recommend for further analysis of the sentinel lymph node using the ultra-staging technique, which is a technique for lymph node examination where we section the lymph node like 2 millimeters apart, then microscopically to 100 microns, and then stain them alternatively with H&E ones and with immunohistochemistry ones to detect any hidden cancer cells. Now I come to the last question I'm going to answer today. What about the molecular? But firstly, let me tell you that the molecular would definitely affect your treatment decision, the prognosis of the patient, and nowadays, while I'm standing, it's going to affect the staging actually. Okay. Okay, complete molecular classification is encouraged in all cases of endometrial cancer, and this is a fact. Let me remind you quickly what are the 4 molecular subtypes of endometrial carcinoma. We have the poly-ultra-mutated with an excellent prognosis. We have the mismatch repair deficient and the no specific molecular profile with intermediate prognosis. And we have the P53 mutant with poor prognosis, and these are their incidences with a mismatch repair deficiency on top. But how am I going to test for these? Actually, I have immunohistochemistry for the mismatch repair and the P53, and there are some molecular testings for poly. Maybe they're not so available nowadays yet in Egypt, but they are in the market elsewhere. And we report the P53 as wild and mutant, by the way. This is something to mention. Okay, but after you do this subtyping, how is gonna the molecular imprint, the molecular subtype affect the staging? Actually, its effect is on stage 1 and stage 2. Okay, let's see. If I have a polymutant case that is within stage 1 or stage 2, let's better say it's confined to the uterine corpse or with cervical extension, regardless of degree of LVI or histologic type, this will downstage the case into stage 1A. On the other hand, if I have another case that is P53 abnormal, confined to the uterine corpse with any myometrial invasion with or without cervical invasion, regardless of the degree of LVI histologic type, I'm saying it's within stages 1 and 2, I will definitely upstage it to stage 2C. And then that means that the polymutant, you will escalate the post-operative adjuvant therapy, whereas the P53 abnormal, you would definitely increase intensive therapy. One last thing that I would love to say, that it's better to include all the testing, all the molecular testing and the surrogate markers, because there is only 5% that is called the multiple classifier, where you can find more than one mutation in the same tumor. Now, let me tell you a question. What do you think if you have a polymutant mutation with a P53 abnormality? Which one would dominate? Any answer? Okay, surprisingly, the polymutant, the one that dominates, and we have favorable prognosis. Same thing if we have mismatch repair deficiency with P53 abnormality, the mismatch will dominate. And finally, the polymutation, the mismatch repair deficiency together, actually there's limited data screening for Lynch. Now the ASGO is doing some updates after the FIGO updates that are pending. Now I come to the end of my talk, and I would always love to shed the light on the importance of multidisciplinary teams, and they bring viewpoints together, and together we make decisions better. These are my references. Thank you so much for your attention, and hope to see you next year. Thank you. Thank you. شكرا لك. Okay, any questions? Okay, thank you.
Thank you, Dr. Dina. Next talk about Hudson procedure by Dr. Khalid El-Wadi, consultant of Gynecology in King Saud University, Saudi Arabia, المملكة العربية السعودية. تفضل.
Assalamu alaikum جميعا. First of all, thank you very much for the organizing committee. Thank you for the Gynecology Department in Ain Shams for this invitation and giving me this opportunity. We will discuss about the radical oophorectomy, or a procedure called Hudson procedure. I have nothing to disclose. We will describe the procedure quickly. We will talk about the difference between the piecemeal peritoneal dissection to remove the tumor from the pelvis versus this procedure. Is it justifiable, and what about the visibility and morbidity? Now, all we know that ovarian cancer is considered the primary lethal cancer among all gynecological cancer, and it's substantially spread through the peritoneum. That makes the pelvis and the peritoneal cavity with the omentum considered the most common metastatic areas. This will make usually the surgery in an advanced cases a challenging surgery, and usually the retroperitoneal is the key for achieving successful surgery in those patients. We all familiar with the survival benefit of residual disease. The optimal cytoreduction is the goal to end up with no macroscopic residual disease at the end of the surgery. This will convey a benefit for our patients with survival, and unfortunately the majority of our cases with advanced epithelial ovarian cancer, where you have to be skillful surgeon, knows where to find them, where to find the disease, and how to remove them safely. So we will focus only on one surgical skill to clear the pelvis. As I told you, it's the most common site to be involved in the posterior cul-de-sac and the rectum, and you will face something what we call it a frozen pelvis. There are mainly two procedures described in the literature to remove or to clear the pelvis in cytoreductive surgery for advanced ovarian cancer. The standard procedure, which is a hysterectomy with bilateral salpingo oophorectomy, followed by a piecemeal stripping of the pelvic peritoneum. It's a good procedure, however, it's bloody and mentally exhausting. The second procedure described actually about 6 decades ago, and it's still functioning and it's still very helpful. We call it a radical oophorectomy or Hudson's procedure. So in the past, the pelvic exenteration designed to cure patients with recurrent cervical cancer have been described in the literature actually for treatment of advanced ovarian cancer. However, it was considered to be too radical for a peritoneal disease. It was till 1968 where Christopher Hudson described this pioneer procedure using the retroperitoneal approach and create a false capsule from the peritoneum to remove in block the pelvic organs involved with the peritoneal carcinomatosis. The objective is basically increase the operability of a pelvic tumor, and the key for success is to use the retroperitoneal approach in those cases. Few years after, they reported their experience with 25 cases, and they found that it's feasible with acceptable morbidity. 1 patient died after the procedure, and 2 patients developed rectovaginal fistula. They were described, they described their procedure with preservation of the rectum. However, at the end, they were going for rectosigmoid resection. In the future, they categorized the procedure into 3 types, mainly type 1 and type 2 and type 3. Type 1, where we remove the pelvic peritoneum and preserve the viscera. So we don't remove the bladder or the rectum. Type 2, where we add a rectosigmoid resection and anastomosis. Type 3, when you have to do a partial cystectomy or urethral resection. Now, evolution happened, and multiple names described in the literature with many modifications. However, the main fundamental concepts and keys or surgical steps still under the Hudson procedure reference point. How about the technique? It's a long procedure, very well described in the literature with a lot of videos describing the steps clearly. You can go and review it. However, from my experience, I found that the main trick to make this procedure easy is to develop the pre-sacral space and get the rectum outside from the pelvis. So you will start, instead of working up and down, you will start working on a horizontal after getting the rectum and the posterior cul-de-sac outside of the pelvis. Now, how feasible and what are the associated morbidity? To be honest, in the literature, the rate of perioperative morbidities and complications varies, and it's hard to estimate because usually those patients, they have another procedure associated with the pelvic surgery in the upper abdomen mainly. However, the main challenging and serious complication related to this procedure is when we need to do a rectosigmoid resection and anastomosis, and is the anastomotic leak. Multiple studies reported in the literature, and they reported an acceptable rate of anastomotic leak between 2 to 3% with acceptable major morbidities. Now, is it justified to go for a Hudson procedure with a rectosigmoid resection? A German group basically did 100% or 100 patients studied prospectively and histologically to evaluate the patients underwent Hudson procedure with a rectosigmoid resection, if the rectosigmoid is histologically involved, and what is the effect on pelvic control and survival on these patients. They found that in 100 patients, almost 2/3 of the patients found to have histological evidence of infiltration, of cancer infiltration of the rectosigmoid, and this infiltration can reach actually down to the mucosa. So with this procedure, it gives us a more ability to clear the pelvis and end up with complete gross resection of the pelvis in up to 96% of the cases. This also was associated with a low risk of recurrence in the pelvis. It was reported at almost 5%. This group also, Nick Spiritus also repeated the same findings in a second look after Hudson procedure. In 72% of the patients, they found that the residual disease or recurrence developed only in 5% of the patients. So basically, it's an excellent procedure to clear the pelvis, an excellent procedure to guarantee a control of the disease in the pelvis. Now, if we want to compare it with the standard of care, which is the piecemeal, Giovanni Aletti from Italy basically evaluated the standard of care, or the peritonectomy versus rectosigmoid resection. They identified 244 patients and underwent cytoreductive surgery, and 1/3 of them underwent rectosigmoid resection, or what we call it a Hudson procedure. 1/3 underwent peritonectomy or a piecemeal peritonectomy, and 1/3 did not receive any peritonectomy in the pelvis, only hysterectomy and bilateral salpingophorectomy. The leaking rate of the anastomosis was acceptable, below 1.7%, and they found that using either or Hudson procedure versus the selective or the piece peritonectomy of the pelvis increased our ability to achieve a microscopic residual disease in the pelvis and increase the number of optimal cytoreduction to less than 1%. When we look in survival in those patients, actually in the patients with both surgeries did very well in survival overall, in comparison to no radical procedure in the pelvis. And when we look into the microscopic residual disease, where the whole disease is removed completely from the pelvis, actually Hudson procedure did performed very well above the piecemeal peritonectomy. In conclusion, Hudson procedure is radical pelvic multivisceral resection. It's a good procedure in advanced epithelial ovarian cancer, and it's a signature operation for us as a gynecologist. It's highly effective to achieve a good complete clearance of macroscopic disease in the pelvis associated with average or average morbidity and anastomotic leak, and it's associated with significant reduced risk of pelvic failure or recurrence. Thank you very much.
Thank you, Dr. Khaled. And now it is radiology time. Any questions for Dr. Khaled before radiology? Thank you, Dr. Khaled. I would like to introduce Professor Alia Shiha, Professor of Radiology, and her talk about role of MRI in cervical carcinoma.
First of all, I would like to thank Dr. Helmi Mutawa for his invitation. I'm going to discuss the key role of MRI in cancer cervix. I will discuss the treatment options, the FIGO staging, post-treatment assessment, identification of refractory disease, and the differentiation of cervical and endometrial cancer. The FIGO staging is used to stage cervical cancer. The latest 2018 revision has incorporated the pathologic and imaging findings to supplement the clinical findings and allowed the inclusion of lymph node status into the staging system. The pathological findings take precedence over the clinical examination. Stage 1B has been classified into 1B1, 1B2, and 1B3 according to the size of the tumor. It better captures superior oncologic outcomes and gives the potential for fertility-sparing surgery. 3C1 indicates pelvic lymph node metastasis. Surgery is indicated radical hysterectomy for the confined tumors to the cervix and vagina less than 4 centimeters. Fertility-sparing approach, either conization or radical trachelectomy, needs the tumor to be less than 2 centimeters and confined to the cervix. Chemoradiotherapy is indicated for cervix and upper vaginal confined tumors with larger size, more than 4 centimeters, and for locally advanced disease. External beam radiation is delivered concurrently with platinum-based chemotherapy, followed by image-guided brachytherapy. So MRI is needed to initially stage cervical cancer. First of all, we need high-resolution T2-weighted images. We need it in sagittal and oblique axial planes, diffusion-weighted images, and the good news is dynamic contrast-enhanced images is not indicated. Yani we don't need contrast to stage cervical cancer. It is just for research purposes. The images are acquired with axial oblique images perpendicular to the cervical canal and coronal parallel to the cervical canal. So it's very important to be done correctly, or else it decreases the accuracy of MRI. Of course, if the cervix is retroflexed or the uterus is retroflexed, this needs to change. We need to change the plan of the imaging. So a radiologist must be present during the examination to supervise for better quality images. Here the axial plane is different because the uterus is retroverted, anti-flexed. Regarding the staging, we have the stage 1 and 2A. 2A reaches the vagina, 2B parameter invasion, 3A the lower vaginal affection, 3B side wall, 3C lymph node affection, and then 4 is bladder or rectal invasion. In the MRI, we have a checklist. We have to identify the tumor size, the vaginal invasion, parameteral invasion, pelvic side wall invasion, hydronephrosis, and bladder and rectum invasion, as well as the lymph nodes. We can assess the distance between the tumor and the internal os for fertility sparing. We can assess the total uterine size for laparoscopic versus open surgery and associated conditions. Here we can see the superb soft tissue contrast resolution of MRI. We can see here the endocervical canal, the internal os and the external os, and the cervical stroma very clearly with MRI. Here we can see 3 types of cervical carcinomas. One is exophytic, the first image. The second is infiltrative, and the third is an endocervical tumor. This is a case of an early cervical cancer with only the arrowed part is signal abnormality within the cervix, and this could be staged as 1B2 because there is no invasion of the stroma and the tumor is between 2 and 4 centimeters. Here, this is a case of vaginal invasion. There has to be invasion of the stroma of the vagina, so this is 2A tumor. This is a case of FIGO 2A, and we can see in the sagittal tumor, the arrow is indicating the vaginal invasion in this case. There is a very important concept. The full thickness stromal invasion is not equal to parameter infiltration. يعني ممكن يكون في full thickness stromal invasion on the left, but still there is no parameter infiltration. We have to see nodularity within the parametrium or encasement of the vessels to diagnose the parameteral invasion. And here is how we diagnose parameteral invasion. The image on the left is the normal hypointense cervical stroma, اللون الأسود اللي هي الnormal cervical stroma. On the right, there is the interruption of the cervical stroma on the right side. So this is diagnostic of parameteral infiltration. Here is a pitfall. You can see a tumor here. It's about 6 or 7 centimeters. It can expand the cervical canal, but without parameteral infiltration. So it can be expanded, not invaded, because I can see this black line, which is the hypointense cervical stroma. This is a case of pelvic sidewall invasion. It is diagnosed when the tumor is less than 3 millimeters from the internal obturator muscle, the levator or piriformis, or any of the iliac vessels, or if I see hydronephrosis in the case. This is a case we can see here. The arrow points to the hydronephrosis of the left ureter, and another case with PET-CT. So this is 3B. This is a case with bladder and rectal invasion. Anteriorly here, the black arrow, the bladder is invaded, and posteriorly, so this is stage 4. This is another pitfall which can be seen the high signal or the grayish signal referred in the arrow is bullous edema of the bladder, so this is not infiltration of the bladder. So in these cases, if MRI suggests bladder invasion, cystoscopy should confirm. يعني لازم نعمل cystoscopy to confirm urinary bladder invasion. طبعا في الحالات اللي هي فيها pitfall, not the very obvious cases. Regarding lymph node staging, lymph nodes in the pelvis and the para-aortic nodes up to the level of the renal veins are regional. لكن para-aortic lymph node metastasis needs adaptation of radiotherapy field. Inguinal lymph nodes and para-aortic above the level of renal veins is considered distant metastasis. Lymph node detection on MRI is based on size criteria and morphology. So لو lymph node exceeds 8 millimeters, this is likely metastatic. 8 to 10 is likely involved. More than 15 is most certainly involved. عندنا كرايتيريا في المورفولوجي بتسجست ان الليمف نود دي ممكن تبقى invaded انها spherical in shape, irregular contour, signal is altered on T2, central necrosis or amalgamated lymph nodes, and central necrosis 100% diagnostic of nodal metastasis. MRI has limited sensitivity, yet because of the discrimination between inflammatory and metastatic nodes could be problematic. Also, it cannot detect micrometastasis. Also, non-specific pelvic masses could be mistaken for lymph nodes. أهمهم الأوفريز، يعني الأوفريز لازم تبقى identified في كل حالة pelvis لأنها ممكن تبقى mixed مع lymph node. PET-CT is more accurate than MRI في lymph node staging. The main disadvantage هو لو كانت lymph node necrotic because it will not give the uptake impact. Here is on the left side is a MRI with a right internal iliac lymph node. It is suspicious but not definitely involved because it's 7 millimeters on the right side. The PET is active, so this is definitely metastatic. Here another case, we have a lymph node on the right side, obturator, which is suspicious on MRI and proved to be metastatic. Of course, in this case, there is parameter invasion on the left side. In fertility preservation, we need the tumor to be 1B1, less than 2 centimeters, more than 1 centimeters from the cervical os, no parameter invasion, and no lymph node metastasis. This is a case, we can see if you can identify here the arrow, this is a small tumor, more than 1 centimeters from the internal cervical os, and we have distended the vagina here with gel to better delineate the tumor. So this is a good technique to delineate the small tumors. Assessment of response of treatment, post-treatment, can be done also by MRI. There is no consensus when to image, but most centers perform the imaging from 3 to 6 months. After the brachytherapy, we have to see the reconstitution of low signal of the cervical stroma, يعني ما يبقاش في abnormal signal موجود. Edema and inflammation can persist up to 6 to 9 months, so it's better to delay the imaging. Refractory disease is residual tumor after 6 months, intermediate T2 signal and restricted diffusion. Again, مش محتاجين صبغة عشان نشخص إنه في refractory cervical cancer. Patients with no evidence of distant disease at FDG PET can be considered for pelvic exentration. Here, this is a case. On the left, the pre-treatment MRI, وزي ما قلنا عاملين distension للفاجينا بجل وبيحسن الفيجواليزيشن بتاع التومر. On the right side في complete response. الجرايش color بتاع التومر اختفى تماما. This is another case. On the left, this is a cervical cancer, but this is a refractory case ولسه في residual tumor في الصورة اللي على right side. This is abnormal signal, and again, vaginal gel can visualize it very well. The last thing is the differentiation between endometrial and cervical cancer. Sometimes cases can be problematic. ما بنبقاش عارفين التومر أصلاً arising from the cervix ولا from the endometrium. وساعات الباثولوجي بيكون برضه not very conclusive. ال MRI في certain criteria. لو التومر centered على الendometrial cavity بنقول إنه endometrial, centered على cervical canal, it's mostly cervical. اللونجيتيودنال spread بتاع التومر, longitudinal pattern بيبقى endometrial, lateral spread بيكون مع السيرفايكل. اللوكو ريجنال سبريد لما التومر يعمل myometrial invasion early بيمشي مع endometrial. الباراميترال invasion is more with cervical. بالنسبه في الحالات دي بقى محتاجين صبغه، لان الاندوميتريال بيبقى هايبوفاسكولار والسيرفايكال بيبقى هايبرفاسكولار، ووجود البارا اورتيك lymph nodes بيرجح اكتر ان هو endometrial. This is a case of a tumor filling the endometrial cavity and the cervical canal. We can see in the second image B, there is myometrial invasion. We can see on the image D, this is a hypovascular tumor. On the diffusion weighted image, there is no parametrial invasion and there are para-aortic nodes. So this proved to be endometrial cancer. So the take-home message is the FIGO staging 2018 allows pathological and imaging findings to supplement clinical findings. MRI is essential for local regional tumor extent and confirming eligibility for fertility-sparing surgery. PET-CT is better in lymph nodes, better in distant metastases. MRI is essential in post-treatment assessment for response to chemoradiotherapy to select cases for pelvic exentration. And MRI has the potential to differentiate endometrial and cervical cancer if the origin is indeterminate. Thank you.
Thanks, Dr. Alia Shiha, for this nice and informative presentation. Any questions? Thanks for the respectable speakers, chairpersons, and the organizing committee for this nice invitation and the great efforts over the 2 last days of the conference. Now I conclude the session, hoping to see you next year, inshallah.